Good morning everybody. Today I am going to discuss our topic, that is asthma and tropical pulmonary eosinophilia. And what is the asthma? Asthma, initially we thought it is due to the allergic condition or allergic diseases that manifest as asthma in case of respiratory involvement. But with the advent of different methods, different clinical trials and different investigation, now it has been found that it is multifactorial. Now come to the definition. So the definition of asthma is not a single line. It is a number of cases or number of definitions or number of lines are involved to define a case of asthma. So the asthma is a heterogeneous disease. The heterogeneous here means it is multifactorial. There are number of conditions that are involved and that give rise to a similar symptoms, and it is chronic and with airway inflammation. And if you know that FeNO, there is the fractional expired nitric oxide that detect this airway inflammation, and it is chronic. That means it is of some duration and causing symptoms, that is wheezing, shortness of breath and chest tightness and cough. This is the only cough is also present in particularly in adults. We call it the cough variant asthma, and that varies in frequency and intensity together with variable expiratory flow limitation. This portion is very important. There is a variability, and variability defines the asthma and it differentiates it from other obstructive airway disease, and it is also differentiated by this variable presentation from COPD. Now come to the risk factors. Risk factors are of two types. One is the endogenous, that is the non-modifiable risk factor, and environmental, that is modifiable risk factor. Now comes to the endogenous risk factors. First one is the genetic predisposition. That is, we know that asthma is called a family disease. Why? Because of presence of atopy. That means presence of some allergic manifestation either in the form of skin diseases, eczema, allergic rhinitis or asthma, that occurs in a particular population in a family. So it is atopy and airway hyperresponsiveness. There is also been involved in the endogenous factor, and it is gender, particularly in the adolescent age it is male predominant, and at the age progresses it is more aged person, it is more predominant in female. Obesity is also associated, and viral infection, particularly after viral infection airway becomes some hyperresponsive, particularly some patient may present the asthma like features but others are not. And there are some environmental factors such as the indoor allergens, particularly dust mite, cockroaches, some insects, and outdoor allergen, particularly pollens, and also some occupational exposure or occupational sensitization, passive smoking also involved, and respiratory infection, particularly a viral infection. Now come to the triggers. The triggers mean that exacerbate the symptoms of asthma. We already described the allergens. Dermatophagoids species, that is called the dust mite, and particularly the Blomia tropicalis is the dust mite that is mostly involved in our tropical countries, and there are dermatophagoids, Pteronicinas are there, and dermatophagoids ferini, and environmental exposure, grass pollen, ragweed is not particularly, it is common in USA, and there are some tree pollens, fungal spores, aspergillus, pet and cockroaches are also involved. And viral infection, particularly the rhinovirus, respiratory syncytial virus and coronavirus, these are the, and influenza virus, these are also been involved in the or acts as a triggering factor for asthma exacerbation. And some pharmaceutical products that blocks the beta blockers, AC inhibitors and aspirin. But and aspirin is also involved because the aspirin induced asthma is a term and particularly occurs in a selected group of patients. Exercise is also there because exercise of vigorous exercise that causes dry up of the respiratory mucus and that causes degranulation of the mast cell, and patient presented with shortness of breath, wheeze and cough after a few minutes after vigorous exercise. And physical factors, particularly cold air, hyperventilation, this is almost similar to that of exercise. This is the pathogenesis is almost same. Foods, particularly the prawn, some kinds of pulses, brinjal, these are also been involved, and these are a particularly subset of population. This food is also acts as a triggering factor for asthma. And air pollution like sulfur dioxide and irritant gases are also involved. Now irritants, particularly household spray, paint, fumes, and occupational factor already described, and hormonal factors like thyrotoxicosis, fall in the progesterone level, and gastrointestinal reflux disease, or better we call it GERD. Sometimes this gastrointestinal content sometimes may ingest into the or enter into the respiratory tract, and that trigger the asthma symptoms. And the stress is also an important factor. Now come to the pathogenesis of asthma, and how this asthma occurs, and what are the cells that are involved in the pathogenesis, and what are the chemokines that are involved. Whenever an allergen is entered into the body, that is engulfed by our MHC class 2 cells, and that are engulfed our phagocytoses, and those are possessed and then are presented to the T cell or CD4 T cell. Then CD4 T cells send it to the type 2 helper cells, and these type 2 helper cells are predominant in the allergic prone population. And this type 2 4 cell that produce the interleukin 4, and that matures the B cells to produce IgE, and then this IgE then on the surface of the mast cell, and whenever this any allergen present, that causes the degranulation after bridging the Fc receptor or bridging the IgE antibodies, and it degranulate and secrete number of chemokines and histamine, and these are responsible for the early allergic response. And patient presented as wheezing, urticaria, sneezing, rhinorrhea, and conjunctivitis. And whenever these symptoms progresses on a regular basis, and then Th2 cell also secrete interleukin 5, interleukin 9, and that mature the eosinophils or recruit the eosinophil at the site of inflammation, and it produces some proteins like the major basic protein, leukotrienes, and cytokines, and that causes the late allergic manifestation, that is the further wheezing, nasal congestion, and eczema. And this pathogenesis is very much important, particularly for treatment purpose. So we can divide the treatment at the molecular level, and we can block some antihistaminics or histamines, some anti-leukin 5 inhibitors are there, and also to reduce the degranulation of the mast cell. So this pathogenesis is important. Now this is a picture. This is the normal airway, and you saw on the cross section the lumen is free, and there is a no muscle is smooth, and it is not hypertrophied. On the right side, during the asthma symptoms, what happened? There is mucosal edema is there now, and thickening of the muscles, and at the same time there is narrowing of the lumen, and there is mucus production or mucus that fills with the internal portion of the lumen. Now see on the cross section. Now comes to the phenotypes. There are many phenotypes, and these phenotypes are very much important because of treatment. Because when we discuss the treatment, this is a common or one blanket treatment with antihistaminics or inhalers is not sufficient to control the asthma. So it has been subdivided, because the predominant features of asthma is due to some other causes. We have to find out the cause and treat accordingly. Then the asthma, the symptoms will be controlled. What is the allergic asthma? Already described. There is some allergic portion is involved. Non-allergic asthma, adult or late onset asthma, that is very much predominant in female, more steroid resistant, and asthma with fixed airway limitation that behave like a COPD, and asthma with obesity or obesity associated asthma. This almost all these last these are non-eosinophilic or non-allergic. Now come to the diagnosis. For the diagnosis, we have to know the symptoms. Depends on the two defining features, the history of the respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity. And the time variability means there is the diurnal variation and also the seasonal variation. The seasonal pattern is there. Either it may exacerbate during rainy season, someone get the exacerbation in case of winter season, but in between the times patient become normal. So this means the seasonal pattern. And also there is a time variability, and because some get the more cough and wheeze at the night time, or some get in the early morning, and there is a variable expiratory flow limitation. Now this is the diagnostic feature already described. What are the history we will get from the patient? There is a wheeze, shortness of breath, chest tightness, and cough. And on the right side, this is generally more than one type of the respiratory symptoms are present, but in adults only the cough may be present. That is called the cough variant asthma. Symptoms occur variably over time and vary in intensity, and often worse at night on awaking or in the early morning, Symptoms often triggered by exercise, laughter, allergens, cold air, and also appear worse on viral infection. So these are the points we have to keep in mind whenever we thought it is going to be a case of asthma, particularly when patient present with shortness of breath, wheeze, chest tightness and cough of some duration. Now how will we confirm the cases? Now we already take the history, now we confirm the cases. That requires investigation. There is a spirometric investigation is necessary to know the airflow limitation. And usually we do our hospital, there is a spirometry with post bronchodilator reversibility test, and in adult it is defined as FEV1 is 12% and 200 ml from baseline after 10 to 15 minutes of 200 to 400 microgram of salbutamol or equivalent or albuterol. That is the diagnostic or confirmatory of reversibility. And it is this reversibility in the spirometry is helpful for diagnosis along with the clinical symptoms. Actually, asthma is a clinical diagnosis, and there are other modalities of investigations are there to diagnose asthma, particularly in case of exercise, positive exercise challenge test, and after vigorous exercise of 8 minutes, that is patient running on a treadmill or any other exercise, there is a fall in FEV1 by 10% and 200 ml from baseline. That is also diagnostic of exercise induced asthma. And sometimes the spirometry may be normal, because we already call is a variable because of variability, and for this reason there is a bronchial challenge test by methacholine that is also been used, and it is also been helpful in some subset of population. Now come to the diagnostic flowchart of asthma in clinical practice. So we have got a patient with having respiratory symptoms, and we have to know whether actually we are dealing with asthma or it may be due to the other causes. Particularly this cough, nighttime cough, shortness of breath, it also occur in the paroxysmal nocturnal dyspnea, and it is not due to the lung cause, it is predominantly due to the cardiac causes. And there may be certain ingestion of foreign body into the respiratory system, it may cause cough, shortness of breath, choking, so it is not due to the asthma. So we have to take the detailed history examination, and we have to confirm it by spirometry and reversibility testing. Then if it is confirmed it is asthma, then we treat in a case of asthma. Otherwise we have to take alternative diagnosis. Now assessing a patient with asthma, what are the portion or during the management, what we have to think? Now assess the asthma control, assess for the risk factor, assess for comorbidities, and assess some treatment issues. Now come to the asthma control. In the asthma control there are some questionnaire, and now the asthma control, this question comes when we got a patient with the asthma, the patient is already diagnosed asthma, now we have to check whether patient is controlled or uncontrolled. So we have some questionnaire, and there are some points on it, such as now come to the question, and we have to take at least 4 weeks treatment patient already get, and then we assess whether the asthma is controlled or not. Now come to the whether the patient has any daytime symptoms more than twice per week, or any reliever medication has to be used in twice per week, any nighttime symptoms that causes patient to arouse, and any activity limitation like your moving upstairs, cycling or dancing or singing. If all the question answer are no, then it is well controlled. If there is yes, there is yes for particularly some symptoms, if it is 1 or 2, that is partially controlled. If almost all the symptoms are yes present, so it is uncontrolled. And we have checked our daily parameters by peak flow meter, and it is very useful at the home basis. We have to check our FEV1 level, and there is a dipping in the early morning, or there is some predictive value according to the height and age of a patient, and whenever it is controlled we have to reach the particular limit. That means suppose a patient comes with 60 kg and height is 160 centimeter, then say his peak flow meter, the FEV1 value come around 350 or 400, suppose 350. So whenever it is controlled, so in one picking or one blow in the early morning, it should go beyond or above the 350. So whenever it comes down below 350 for consecutive 1 or 2 days, it is supposed to be due to there is a possibility of exacerbation or there is loss of control. Now, assessment of the severity, there are a number of questionnaire and the parameters are there, and we can divide the patient intermittent, mild, moderate and severe persistent asthma. Now come to the assessment for the risk factors, and whenever we are treating a patient with the asthma, we also know what are the risk factors present in the patient, and if it is not addressed properly, so there is maybe chance of exacerbation. Risk factor for exacerbation, first one is the uncontrolled asthma symptoms. The dose is not adequate, patient is not taking regularly, any comorbidities, your patient with hypertension, diabetes or any allergic rhinitis, exposure to smoking, allergen and air pollution, and major socioeconomic problems and medication, particularly inhaled corticosteroid not prescribed, poor adherence and high SABA use, and incorrect inhaler technique. Now, risk factors for developing the fixed airflow obstruction. There is the preterm birth, low birth weight and greater infant weight gain, lack of ICS treatment, exposure to tobacco smoke and noxious chemicals, low FEV1, chronic mucus hypersecretion and sputum and blood eosinophilia. These are also been an indicator that your ICS level or ICS treatment is not sufficient. Then we have to increase the inhaled corticosteroid dose. And risk factors due to the medication use. Frequent oral corticosteroid, if it is used, that leads to the osteoporosis, GI symptoms, development of cataract, development of diabetes, and long-term high dose or potent ICS use and poor inhaler technique. This is very much common in patients, particularly hand-mouth incoordination is very much present in aged patient with some tremor or Parkinsonian disorder or dementic patient. And instead, now a patient has been advised to take the nebulizer instead of inhaled corticosteroid or dry powder inhaler. Now, assess for comorbidities. Whenever we are going to treat any asthma patient, we have to treat these comorbidities also to get the control of asthma symptoms. If there is allergic rhinitis present, go for antihistaminic or antihistaminic nasal spray along with the corticosteroid. Chronic rhinosinusitis has to be treated. GERD with pantoprazole inhibitor. Obesity that requires weight loss. Obstructive sleep apnea, that is sometimes associated with obesity. So, whenever the obesity is getting under control, so the OSA symptoms also control. Actually, this OSA also increases, OSA is increased by GERD. And depression, anxiety, this is the mental status is very much important. And pregnancy, in the 1/3 cases of pregnancy, there may be loss of control of asthma. Now, some treatment treatment issue are there. Record the patient treatment and ask about the side effects. Check the patient has a written asthma action plan is there, and also ask the patient about their attitude and goals for asthma. That means there is a adherence with the treatment. There are written asthma action plan is there. There are some questionnaires patient has to fill up daily, and according to which the patient can identify that whether he is well or there may be some possibility of loss of control or chance of exacerbation in the next 2 or 3 days. And whenever there is increase in the medication, how to use the medicine or oral corticosteroid is also been addressed in the asthma action plan. Now come to the management. The purpose of the management is, first one is the symptom control and second one is the risk reduction. Symptom control, few asthma symptoms, no sleep disturbances and no exercise limitation. And risk reduction, that means it prevents the flare up or exacerbation, prevents asthma deaths and avoid medication side effects. Now come to the management. We can divide into the general management of asthma medication, treatment of modifiable risk factors, particularly those triggers or environmental factors, treatment of comorbidity, non-pharmacological therapy and follow-up. Now general management, there is the patient education, inhaler skills, adherence, written asthma action plan, self-monitoring and regular medication review. This also has been checked during the time of visit. Now come to the asthma medication. We divide the asthma medication as a controller medication, add-on controller medication and reliever medication. Now controller medication, and as it is the eosinophilic lung disease, so inhaled corticosteroid is the best treatment. Now it has been found that ICS and LABA combination or long-acting beta agonist is the preferred over ICS, and there are also the leukotriene modifiers and chromins. ICS, those are available. There is the beclomethasone dipropionate, budesonide, fluticasone propionate, fluticasone furoate, cyclesonide and triamcinolone. And ICS LAVA combination is there. There is the beclomethasone formoterol. Now the extra fine particle of it is available. That means the drug deposition goes to the terminal or this bronchial size less than 2 millimeter or terminal bronchiole. And there are budesonide formoterol combination, fluticasone, propionate and formoterol, and other preparations ICS LAVA are also there. Now controller medication is also, there is the leukotriene modifier and chromones. And there are some add-on therapy, and this add-on therapy for controller medication, these are used for subset of population where there is the allergy is predominant, particularly anti-Ig or omalizumab, anti-IL-5, mepolizumab, and some monoclonal antibodies are there, and that has to be given in a particular population. Another systemic corticosteroid is used when there is a uncontrolled with inhaler medication or patient getting the inhaled corticosteroid in a maximum or optimum dose. Now come to the reliever medication. Despite the treatment of controller medication, there are sometimes patient got some symptoms of cough, wheeze. So in that time we have to use the short acting bronchodilator or SHABA on SOS basis, or low dose or ICS formoterol can be used. Now reliever medication, there is the already described, there is the short acting bronchodilator, there is the salbutamol and terbutaline. Now come to the reliever medication. There is the low dose ICS formoterol and short acting anticholinergics. These are also been used as a reliever medication. Now come to the non-pharmacological therapies or strategies. These are also been useful to control the asthma symptoms or to control the asthma. First one is the cessation of smoking, or any type of smoking pattern. Even the e-cigarette is also been banned because of its detrimental effect. And physical activity, that is patient is advised to do more physical activity. Actually it decreases stress and your respiratory symptoms are also improved. Healthy diet, that means diet contents of vitamin C, D and E, these are also been helpful. And weight reduction, just to reduce your weight, and that increases your lung function. Breathing exercises and avoidance of the occupational exposure, particularly whenever we are exposed to the occupational or environmental exposure to the noxious gases or allergens there, we have to use masks. And then avoidance of the indoor allergen and air pollution, avoidance of outdoor air pollution and weather conditions, and avoidance of the medication that may make the asthma worse, particularly the AC inhibitor and beta blocker. Now other therapy, there is the allergen immunotherapy, there is the subcutaneous immunotherapy kit or SLIT is there, and these are also been advocated for particular type of population, those having with allergic rhinitis, or these are associated with the allergy to the pollen and dust mite. And bronchial thermoplasty, in very severe condition, some patient may be treated with the bronchial thermoplasty. Now there is a GINA 2019, there is a stepwise treatment. Whenever we treat the patient, it should be given in an optimum dose just to reduce the symptoms, and after follow up of 4 weeks, that there is some questionnaire just to differentiate whether the asthma is controlled, partially controlled or uncontrolled, and according to it we can step up or step down. Or there are some other medication, whenever the patient comes into the step 5, we have to use other things like add-on therapies are there, particularly anti-Ig, anti-interleukin 5 receptor antagonist, and there may be subset of population or patient may get sublingual immunotherapy or subcutaneous immunotherapy. There are some basic difference between the asthma and COPD. Those still they are presented with the shortness of breath, cough and wheeze, and both are treated with inhalers and some medications. But there are some basic difference. Asthma is a predominantly eosinophilic condition and COPD is a neutrophilic. And asthma not always there is productive cough, usually reversible and often associated with some allergies, and cough at night and early mornings, and there is family history and there is a variability. This is very important. Whereas the COPD, cough is usually productive, symptoms are not reversible, or there is a progressive disease and associated with smoking or other household exposure or biomass fuel, and cough in the morning and throughout the day, and aged, particularly occur in the aged population. And there are some differentiating points between COPD and asthma. Now come to the management of asthma is in the time of exacerbation. Management of the exacerbation in the primary care. First one, we have to assess the patient whether actually it is a asthma, or it may be some cardiac causes, or it may be due to the other causes. And if there is a patient is already found to be asthma, then we have to find whether there is a risk factor associated with related to death and severity of the exacerbation, whether it can be treated on outdoor basis or emergency or ward, or it can be shifted to ICU. So mild or moderate disease, patient talks in phrases, there is a respiratory rate is increased, and pulse rate 100 to 120, saturation is maintaining between 90 to 95% of room air, and peak expiratory flow rate 50% of the predicted or best. On the severe disease, the toxin words, and there is a respiratory rate more than 30, accessory muscles are in use, pulse rate more than 120, and saturation is less than 90%. These patients are very much notorious to develop into the respiratory failure or life-threatening. Patient is drowsy, confused, and silent chest. These three are very much important. Whenever we got a known patient of asthma getting the silent chest, patient has to be shifted to the ICU immediately and has to be intubated. Now there is a mild and moderate cases. We have to treat with the short-acting bronchodilator either in the PMDI or spacer or nebulizer. Or nebulization, and we have to give the prednisolone or corticosteroid are given, and also the controlled oxygen. And target saturation will be 93 to 95%, in children 94 to 98. Then we have to reassess the patient after 1 hour. If the patient is improving, discharge with the medication. Sometimes we have to increase the dose of controller medication. If the patient symptoms remain same or patient become deteriorating, like patient is getting mental status, patient become confused, saturation is not maintaining, and chest become decreased sound or become silent chest, then patient is getting worse and we have to shift the patient to ICU. Now in the critical care situation there is the drowsiness, confusion or silent chest, there is the consult ICU and patient prepare for intubation. And if it is not, there is the trigger by other clinical status according to the worst feature and mild to moderate disease, and patient has to be treated accordingly. So overall, this is the management and of asthma, and how to differentiate asthma from other disease is very much important, because this cough, wheeze and shortness of breath, these are almost common feature in case of the paroxysmal nocturnal dyspnea, chronic heart failure, and sometimes foreign body aspiration. So we have to take the history carefully and treat accordingly. Now we come to the another topic. There is a topical pulmonary eosinophilia. It is also a eosinophilic lung disease, and there is a picture almost similar that of asthma, and we have to take the proper history, and geographical distribution of the patient is very much important to diagnose a patient of topical pulmonary eosinophilia. So it was first described early in 1940s by Weingarten in India, and the symptoms are like malaise, anorexia and weight loss, paroxysmal dry cough, dyspnea and wheezing, marked peripheral blood eosinophilia, and spontaneous resolution over weeks. And these are most common in the India, particularly in the Southeast Asia and as well as in the Africa. Actually, it is the rare manifestation of the parasitic infection, and that is 1% of cases it occurs in case of lymphatic filariasis. And it is due to the hypersensitivity reaction to the microfilari from Wuchereria bancrofti and Bugia malawi. And age group between 20 to 40 years of age, although the children and other older adults may also be affected. Predominantly more common in males than females, and there is a immunological hyperresponsiveness. And presentation we already described, and on physical examination we get the coarse cackles and bronchi, and generalized lymphadenopathy and hepatosplenomegaly may be present. These are very much important, particularly extrapulmonary manifestation of the Bugia malawi and Triponema. Now comes to the laboratory findings. There is a extreme peripheral blood eosinophilia. It is more than 3000 per microliter, or serum Ig is very high. This portion is very much important in case of IgE. This value of the serum Ig, and it indicates there is a inflammation is the chronic, and there is a high titers of the filarial specific IgG and IgE. Both are important, and these are helpful for the diagnosis. And sometimes bronchoalveolar lavage for eosinophilic alveolitis. And microfilari, we can't detect the microfilari directly in the blood or sputum, so we have to depend on the serological diagnosis. Whenever the patient come with the symptoms of a particular region, particularly the eastern coast of the India, in Odisha and some portion of the West Bengal, and patient has this type of symptoms and having the peripheral blood eosinophilia and serum Ig level is high, and then we have to think of it is due to the topical pulmonary eosinophilia and due to microfilari. And pulmonary function test reveals an obstructive ventilatory defect in up to 30% of the patient, particularly when the symptoms have been present less than 1 month. and there is a restrictive defect when there is in the prolonged period or it becomes chronic. Now this is the radiological findings. There is the bilateral indefinite mottling uniformly distributed in the both lungs, middle and lower zone. Now what are the treatment of topical pulmonary eosinophilia? There is the diethyl carbamazine. There is a dose of 2 mg per kg of body weight that has to be taken orally 3 times a day for 14 to 21 days or as long as 4 weeks. And there is a filaricidal to both adult worms and microfilary. And clinical improvement occurs dramatically within 7 days of administration. And acute relapse, we have to use it 2 to 4 mg per kg body weight and repeat for 21 to 30 days. And there are some alternative other drugs are there, antifungals such as ivermectin, and some cases we have to use corticosteroid. May be useful in therapies in chronic variant of the disease. And untreated TP or topical pulmonary eosinophilia that develop into the chronic interstitial lung disease, and then it becomes irreversible stage. Thank you for patient hearing.